Thanks, Gordon. So I put a question there because I think it's actually important to frame this in terms of, can we generate something that would be of use to people? And I hope I'm going to persuade you that there is an option here. This is a sort of little bit of a disclosure, and it probably tells you a bit about who I am. I'm currently employed by Monash University, although I do some work for other groups, including HRECs. It was good to see Colin today, who I've had a long working career with. I'm just going to sort of open by saying, if you go to I work in health, if you go to every single state and territory in Australia, every one of them has come up with a digital strategy. We're going to be more patient-centric. We're going to use data to do various things, connect care. And everyone has more or less come up with their own version of a strategy. Now, what's difficult about this, and I suppose, and I didn't really mean to be negative about the last presentation in terms of those triage tools, is I think we fundamentally do not understand the difference between research evaluation and ongoing practice. They are a continuum. To try and create a line between them is actually not helpful. Research is a methodology, it's a tool, it is not a category. And I, having worked in hospitals for the last 20 odd years, longer than I care to think, I just think that dichotomy doesn't serve us well. And particularly if you read these digital strategies and then say, how do we deliver on them? If we continue with our current mechanism, we will utterly fail to deliver on the strategies. And I'll tell you why. Now, because I am involved in clinical quality registries, I'm just sort of going through this life cycle. We don't do this work for personal edification or fun. We do it because at the end of the day, we want to deliver better care to the community. It is the absolute driver of what we do.
Sorry, Nick, just a brief interruption. Can you put your thing on slideshow, please, or just...
Oh, sorry, I thought I've got it on slideshow. It's probably... Oh, here we go. Trick it this way. That's probably done it.
Awesome.
Perfect.
Thanks.
Okay. So working with too many monitors. So I think the issue here is that we have this cycle, this life cycle of giving information back to the health service. This is a so-called self-improving healthcare system. We need to generate wisdom from the data, and so it is a cycle. But what is the challenge? Well, we know that healthcare is becoming unsustainably expensive. We're at about 10.5–11% of GDP. We don't want to be at the 17–18 of the US health system. We really had a lag in health systems. We don't have universal interoperable. I've been involved in working across multiple states on their electronic medical records. In Victoria, 78 health systems, or 76, depending who you ask. There's no interoperability between the various health services. Is the data structured? Not like you would like to see it. Very good when you want billing, not so good outside of the clinical coding. Is it accessible? Absolutely not. And if I was being critical, now I'm not working in a hospital, I guess I can be a little, the amount of investment that is actually put into the so-called promise of digital health has been, quite frankly, pathetic compared to the promise of what we're trying to deliver. And I think if you walked into an institute and said how many people are employed to try and utilize the data in a more clever way, you would be you would struggle to meet these people. And also, in my experience, there is a real profound misunderstanding of privacy and confidentiality, and I'm going to tell you that. And again, analysis of healthcare data in a system is it research, is it not research, I think is a futile discussion. So we've got issues because we do need to define what is personal information, and lots of information about a person is personal information. And sometimes we get all het up in, is it this, is it that, is it the other? It doesn't really matter. It's information about a person, and they have a sovereign right about that information. But interestingly, the law says that health services own the data, but we won't go into that debate. And maybe if we have got some time for questions, we can get into it. But there's also massive, massive worries because data is getting hacked. I'll allude to a book later on written by a good friend, Malcolm Crompton, former privacy commissioner, that said there are two types of organization: those that have been hacked and those that don't know they've been hacked. And I think that's like, you know, because we're both cyclists, there's people who've fallen off bikes and those who are going to fall off bikes. What is privacy? And Malcolm put me onto this from 1890. It's not just about the idea that we're putting all these locks and things of it, but it's the very act of invading a person's privacy without their permission, without them knowing about it. It is a mark of, you know, potential disrespect. But then there is this whole utilitarian argument of maybe, just maybe, there are times in which we should trespass on this right because there is a public interest in doing the work. And this is something we can debate a little bit later. And again, you know, I've put the references here and the acknowledgements of where I get these from, but we often have a privacy and confidentiality as though it's it's something that's said together without actually understanding the distinction. And we have ideas where people say, well, I have access to the information in the hospital because I'm entitled to it. But actually, do they really, you know, and in fact, there is a line drawn. When working in a hospital, can't look at patient data willy-nilly. I can't look at my own data because I would be dismissed if I were to do that. So again, there are these things that are the rights to privacy of individuals versus how we manage that information in professional areas. And goodness, it's hard. I mean, I presume everyone on this meeting has read every single one of these acts and is conversant with what they say about the health privacy principles. Again, that universality of, can we just agree that it's health privacy principles, information privacy principles, Australian privacy principle, you know, which is it? So when you're a researcher and saying, right, I want to do something across more than one jurisdiction, or I want to do things across public and private or various areas, it is contradictory in some areas. It's not aligned particularly well. And if ever there was a concept for doing something with some level of intelligent informatics, this possibly could be there. But again, this is, you know, you've got to find out what you've got to do, what are the controls in the organization, and then how do the approvers know how to work with it. And again, APPs won't go into detail about this. You know what they are, but it's all about the privacy principles that we're all supposed to know about. But there has been a review, and you know, I speak to a lot of my colleagues and say, "Oh, you're aware of this review, right?" And they go, "No, not sure about that at all." And then if you do a word search for research through these documents, I suggest that you download all the acts and actually search for research and ethics and various other things. You'll be surprised at how little it's actually in there or how it's defined. Consent may present challenges for research organizations conducting research in the public interest. The government agrees that researchers should be able to rely on broad consent. Right, that's going to challenge some ethics committees I've worked with who don't like broad consent. And we've had these challenges of saying, is that sufficient information? I'm going to comment on that. But the proposal in 14.3 was also to consult further on developing, because we've had arguments, and I've worked with ethics committees that said, well, Section 95A is not consistent with 95, and it's not consistent with some of the way it's described in the national statement, and therefore, which one do we follow? And to make matters worse, we've also got the Data Availability and Transparency Act scheme, which again, this is a nice flowchart that you can see on their website, but it's not exactly clear how one can interact with this. I think this is a marvelous piece of legislation. I think it's amazing what it will allow us to do, but very few people have embraced its capabilities. And it's also because of the definitions about, are you an accredited user? Can you be an accredited data service provider? How does one become that? And if we're doing research, I mean, at the end of the day, I work in cancer and I want to know why people are not receiving the appropriate cancer care. Cancer Australia says, put out a call for funding at the moment saying, how do we evaluate whether the optimal care pathways are being followed? Well, I can tell you, it is almost impossible in the Australian healthcare system right now to do data analytics of whether or not patients are indeed being treated according to the optimal care pathways. And I challenge anyone to say otherwise. But then you look at some jurisdictions have done some really nice work around the exemptions around, well, is that really research or is that health evaluation? And so the Information Privacy Commission in New South Wales have got this statutory guideline on management of health services separate to research that says, well, and this is, you know, this kind of tree of decision making, or if you use this checklist, then you can end up. But where it trips up is it starts getting into de-identifying is the important thing. And I'm going to say that the act of de-identification, and Nusha's talk right at the start was great to see that, is that in itself doesn't change the ethical issue. You know, if I'm handling hydrochloric acid in a fume hood wearing protective gear, that doesn't mean that the hydrochloric acid is not dangerous. And I'm not going to suggest that health data is, you know, inherently dangerous, but it doesn't change the fact that I should treat it with respect and there should be ethical principles still applying to it just because I've de-identified it. And does consent give you all powers in the world? Well, not necessarily. Anyway, just flagging that we're working on this in Victoria, the Health Records Act. And the statutory guideline on it is a bit out of date, but we're working closely with the Health Complaints Commissioner on this through Monash Partners. And these are the kinds of statements under G. If the use or disclosure is necessary for research or the compilation or analysis of statistics in the public interest. And then it goes in about impracticability and can't you get consent? But if you've got broad consent, you just simply said to the community, by the way, just like Coles does, just like Facebook does, just like everyone else, and we just go, yeah, let's scroll to the good stuff and let's just tick the box without reading, you know, 43 pages of agreement. We're privileging health in this way, but a lot of people aren't asking the question, what's being done? Who's doing it? How are they being managed? What are the frameworks to do that? And that's where I'm going to come on to in the latter part of my presentation. So the national statement, I'm just cutting and pasting, and I'm saying, do you need ethics review? Well, yeah, maybe. And I think this is the problem sometimes when because I've set up non-HREC processes for low risk research. But frankly, we need to work with the researchers quite often because we need to go, yeah, but do you need that data? Is that actually going to answer your hypothesis? And often we find them saying, no, actually it doesn't. We go, right. So if you don't use that information, you've now categorized yourself into a lower risk category because you aren't doing things that are more risky. And that's where the synthetic data also comes into it. And we can talk about that. And there's going to be a great presentation in the next couple of days. So the national statement allows institutions to set up efficient and proportionate reviews of lower risk research. This means that, you know, for health services research, is that inherently lower risk? If a person that would ordinarily see the data in the hospital is doing the work to do the evaluation, is that low risk? Does it actually trigger the need for a waiver of consent? This is where there is uncertainty. And I think this is an area that we need to debate. Institutions that establish non-HREC pathways have to make sure they do it competently. And now I've set that up at 2 hospitals and it's working relatively well. I still sit on one of them. And what I'm going to skip to though is, and this is going to be something that I know my colleague and friend Mark is going to talk about, is where institutes have actually implemented waivers of consent, they're supposed to tell you about it. Now, I still haven't found an institution yet in Australia that actually does that. And please disabuse me of that in the chat if there is one, but I haven't found one. So coming on to Malcolm and Michael's book, which I have a copy of here, signed. It's a great book and it's quite prescient. It's as valid today as it was in the years ago. What is it now? 6 years since it was published. Goodness, look at that. It's Wednesday, 28th of November, so almost 6 years to the date. What does it say? It actually says, given that we're going to be doing this work, is there a better way to do it? Can we move from simply these applications to ethics committees where everyone struggles to understand all the legislation, or should we set up frameworks that embed this? Well, guess what? People like the AHW have already done that. They've got a data governance framework, and this is a really robust way of doing it. What does it mean? It's a system of decision rights and accountabilities for information-related processes. So you set up and embed these systems in the organization, and that to some extent can then substitute for the ethical review process because it's a privacy by design, a research ethics by design approach. And that's where I think we really need to go. And if you look at it, this is just an extract from that document from the Department of Prime Minister and Cabinet saying, how do you get trust in government? It's all about trust. What are you doing? Where's the leadership? Who's the data custodian? Can we even see this? Have you articulated your assessment against the 5 safes? Now, when we published a paper some years ago about what patients think about biospecimens, they more or less said to us, at the end of the day, the consent form is the least useful document. What we want to be asked doesn't have to be 40 pages long. What we want to know is, are you a trustworthy organization and how are you accountable? And that's what I think we need to do. Now, I helped set this up with colleagues, Paul Tellman and Matthew Bellegarde. This has been in operation several years, approved by an ethics committee in Australia, who said, well, what's there to approve, really? Because this is not a research project. It is a framework for ensuring that there is ethics by design, there is privacy by design. So there is public interest in using health data. I think we don't have to argue that, but it's really hard to navigate it right now. And I would say there's a lot of people being put off this. And I can tell you, all the registrars, all the medical students, all the nursing, allied health students are absolutely hampered from doing good quality research, which will improve the lives of patients because of such a byzantinely complex system. What's the alternative? Well, I think it is data governance frameworks, training, culture, and of course, public engagement and involvement in all elements of the process. So with that, I'll pass on to the next speaker.
Thanks very much, Nick. That was great. And I have to say, this whole the privacy principles and everything is something that I always come out and ask my team about, and so I'm glad I'm not the only one that gets a bit confused by it all. We'll see if there's anyone in the audience want to put up a question, either put it in the QA or the chat. Just noting that there are quite a few of the HRECs do list all of the projects that they have done waivers of consent for. So I guess with there seems to be, you have the Australian government putting out all these principles, and then each state does their own. Is there any moves to try and get rid of that level so that we can all have a better understanding, we're all working towards the same principles?
Well, I think that's, in a federated system, that's what we want to achieve. That's where we want to go. I'm very glad that there's several groups now pointing out to me that there are actually websites. It has been a few months since I looked. I can tell you I did look at some of them and they weren't there. So I'm really pleased to see that. But I think that national approach of saying this isn't something to hide, this is actually something that's really important to do. It is nationally important, and we should have a harmonized national approach to what we do that guides everyone. Trouble is, my experience again in working has been that every single organization, it's not just the states and territories, but every single organization wants to tweak their little bit and go, but we've got it a little bit different. We're different over here. We want to do it our way. And I wish we'd just stop doing that and adopt and go, hey, that's a great way of doing it. Let's just do it that way.
Yeah. Yeah, I guess the other thing that we often see, like with Metro North, and I'm sort of sure all of the HRECs have this situation where a lot of the health staff have a conjoint appointment with the university. And it's like, well, okay, I can access maybe that information if I've got my Queensland Health hat on, but if I've got my university hat on, they kind of think it's the same. Yeah, that's always a difficulty.
It is, and if you have that duality of being a clinician and a researcher, that you sometimes have to pretend you haven't seen the data that you've really seen. And so again, this is creating a slightly weird circumstance.
But honestly, Lynn, I mean, that's a construct of convenience as opposed to something real. Like if you're a clinician and it says in the Hospital and Health Boards Act you can use data, doesn't really matter you have a university appointment as well. It's just a weird interpretation that really does not help researchers out at all. So yeah, Queensland's a bit weird that way. There you go.
Yeah, but it's getting that message across to them. I've managed to have a completely blank start. No, my screen's come back. Yay. Okay, well, thanks very much, Nick. That was a great presentation.